Welcome everyone. My name is Brad Chickwin. I'm the Education Coordinator here at Lisbon EMS. I was asked by the Chief to put together a presentation around interfacility transfers and how we will address them here in Lisbon. This may be different than those of you who are PIFT medics outside of Lisbon EMS. So first and foremost, Lisbon EMS is not a PIFT service. In order to be a PIF service, you have to have another certification attached to your EMS licensure, and we do not have that here in Lisbon. So if you are a PIF medic working for another agency, that's okay, but please know that you cannot transport patients at the PIF level while employed here at Lisbon EMS. So our mission is to perform interfacility transports when approved by the chief or the deputy chief to help relocate patients to the appropriate healthcare facility to meet their individual needs. Lisbon EMS defines an interfacility transport as any request from a healthcare facility, either emergent or non-emergent, to move a patient to a specialty care designation, residential institution, and/or private residence. So the course objectives, we're going to review the main EMS interfacility decision tree. We're going to clearly define what a stable versus an unstable patient is, introduce the Lisbon EMS transfer flow sheet, cover the expectations of your documentation of these interfacility transports while here at Lisbon EMS, and then we're going to go over some scenarios where you get a chance to walk through the decision-making tree using our interfacility transfer flow sheet created here for Lisbon. So as it pertains to the interfacility transfer decision tree, the most important thing we need to understand is patient stability. Now, ironically, using this main EMS interfacility transfer decision tree, stability is up to us as providers, but is actually defined by the attending physician. So this is where the conversation piece will come in when we get a chance to actually see our patients at the bedside. What it likes to dive into and cover is what disease or injuries is the patient suffering from? What's the history of these injuries? Are these transfers truly time critical or time sensitive? What's the likelihood that with the treatments that have been given, we'll keep the patient stable for the duration of our transport? And then when we transport them, will those therapies work? Or if we can initiate therapies in the field that actually help benefit the patient? So our number one priority when we show up at these facilities to take these transfers is we have to help determine if the patient is stable or not. What are the current needs of the patient, meaning what license level should these patients be transported at? And then we really have to think, what could happen to my patient during this transport? So we're going to start off by discussing things that we should not be transporting here at Lisbon EMS because, again, we are not PIFT certified. So to define unstable, it's any interventions requiring to stabilize a mental status or vital signs that are abnormal within 2 hours prior to this transfer request. Meaning if any patients we are transferring comes from an emergency department, they should be considered unstable or have a high potential for instability, unless through your assessment and your discussion with the healthcare providers on scene, you can convince yourself otherwise. So what are some examples of unstable patients? Any patient with inevitable airway compromise, acute MIs with your pulmonary edema or hypotension, any trauma patients needing a variety of different fluids to include pressors, anybody who's intubated, anybody who has truly abnormal vital signs, someone who is an unstable cardiac rhythm that's been going on for a long time, let's say unstable VTAC, on and off of VTAC, that would be considered an unstable abnormal vital sign that we should not be taking. Also, if these patients have a high potential for instability, so there's a really good likelihood that these patients are going to crash on the way to the next facility, Again, first and foremost, typically is airway. Liable blood pressures, so these are the ones where we see a difference in blood pressures depending on the medications given. Ongoing uncontrollable bleeding, so again, any of those multi-system trauma patients that can be bleeding either internally or externally, we should not be taking. Any of our respiratory distress patients that are acute, that are on CPAP and BiPAP, not on a regular basis. Again, acute MIs, and these are your active STEMIs that they're unable to stabilize in an ED and they just want them out of those EDs. And then again, those patients with multiple long bone fractures, as an example. Still going down that road of a patient being unstable. So again, as we kind of touched upon, these are the ones that have that high risk of deterioration on the way to the hospital. These are those patients that have multiple drips going, they're on vents. These are the ones that typically in the room have respiratory therapists staying there by their side, maintaining this patient. They have the balloon pumps, they're on ECMO, so again, they have multiple staff trying to deal with these patients. Again, anybody who's post-ROSC or who we've brought back and we've brought to an ED, these are considered highly unstable patients. And again, because of the treatments needed for these patients that fall into the PIFT realm of things, we should not be taking them. All of these unstable patients require a critical care transport. In the state of Maine, that's typically Lifeline of Maine. We also should not be taking these patients if they're offering to put an RN, a respiratory therapist, or even a physician in the back of the rescue. It's just not appropriate for Lisbon EMS to take those patients. So here is a list outlined by Maine EMS of medications that could be given to these patients that are unstable, that are PIFT medics. Again, we are not PIFT certified, so if they're on any of these actively, we should not be taking them. So a couple general rules of thumb. So if we're requested to transport any of these patients, and this is how they present, we should not be taking this transfer. We need to turn these down. So first being a paramedic level transfer without a paramedic level crew, that's kind of common sense. Multiple EMS providers in the back having to provide direct patient care just to stabilize these folks. Even something as simple as 2 providers in the back, one to maintain patient outcomes while the other one monitors a Lucas. Again, we should not be taking patients that actively have a Lucas in place as a transfer. IV medications that are infusing that are not listed in the Maine EMS protocol book, so back to that list of PIFT medications. Maintaining or any procedures or interventions outside of our scope of practice, so if these patients again are vented, if they have chest tubes or anything of that effect, we should not be taking these patients. Any transport requiring a nurse, a respiratory therapist, a doctor, a DO, just to supplement the crew because of the instability of the patient, we need to turn those ones down. Any patient whose care is downgraded to meet the level of the transporting crew. So where would we see this? A lot of times with patients that are septic, they also need antibiotics. It is not appropriate for us to show up at any facility with a patient who has one of those PIFT medications, antibiotics being one of them, and they simply say, we'll stop flowing those meds, you get them to the hospital and they'll restart them. That is not appropriate. We need to advocate for our patients to make sure that that care is continued. There's a huge liability on both the hospital and us for accepting those patients. So those are the ones where you need to have the discussion and we will turn those down and give them to a crew that can take them that's either PIF certified or Lifeline of Maine. And then any care required outside of the Lisbon EMS therapy provider level cross-reference matrix that we will review later on in this PowerPoint presentation. So what we should be transporting. These are the stable patients. So these are the ones that have no risk for deterioration, a low risk for deterioration, or a medium risk for deterioration. So what we try to do here in Lisbon is make it very clear on the types of patients that our crews can take, knowing that we may have our transfer crew that's only at the basic level or the advanced EMT level, where ideally we should have one at the paramedic level, but that might not necessarily always be the case. So to kind of break it down for us, if we have a basic level crew, so 2 basics, The only patients we should be taking in these transfers, whether it's from hospital to hospital or hospital to home, are the ones that are on basic oxygen therapy, so either room air or nasal cannula only. We need to monitor the vital signs. We'll discuss that later. A saline lock in place, so no fluids running. A Foley catheter in place is also considered a BLS skill, and my goal is to do some follow-up training on Foley catheters, so some of you folks may not be familiar with what a Foley catheter is or how to maintain them, but we'll cover that later in a different program. And then anything requiring just a simple BLS assessment. When it comes to a low deterioration patient or low risk for deterioration, this is where the advanced CMT level comes into play, so they can maintain any patient that has the treatment needs at the basic level, to include intermediate O2 therapy, so this would be a non-rebreather to get them from point A to point B. This is with a continuous O2 monitoring, and the reason why this is bumped up to the advanced level versus just the basic is advanced should have a little bit more of a concept on grasping how to treat a patient if the SATs start to change and recognize those signs and symptoms during the advanced assessment. Any patient has running IV fluids being just normal saline or lactated ringers. And then anybody who requires blood glucose monitoring, that is appropriate to take at the advanced level. When it comes to the medium risk deterioration, so here's our paramedic level calls. The ones that have advanced O2 therapy, so ones that have CPAP or BiPAP, typically these are the ones being discharged home. Usually they're on these CPAP devices, so they're familiar with them. So there's little to no patient education regarding these CPAPs. Continuous end-tidal CO2 monitoring. We know that end-tidal CO2 can be applied at any license level, but paramedics are the only ones expected to know what the end-tidal CO2 monitor readings are and how to treat them. Any patient requiring EKG monitoring, whether it's 4-lead or 12-lead, must be transported by the paramedic, because remember, advanced CMTs and basics cannot interpret EKG rhythms. Any main EMS protocol medications being given kind of outside of the IV fluids, pain medication, D10 for diabetics, anything that has an advanced level advanced level assessments needed within that medication being given needs to be taken at the paramedic level. Any medications on a pump, remember medication pumps, any of these IV ones should be put on pumps, but a lot of times they are not. But if you have a patient who is on a medication pump, please make sure that those patients are at the paramedic level. And then anything requiring an advanced assessment. Here's a list of the main EMS approved medications that you don't have to be a PIF medic to transport, but you do have to be a paramedic to transport. They're also in your protocol book. Now what? So let's start to discuss our Lisbon EMS interfacility transfer flow sheet. So while you're taking this program, you should have beside you or out front of you a few documents. One being the Lisbon EMS interfacility transfer flow sheet. Another one being an example of the EMTALA. The third one being an example of the provider's orders. And the final one being an example of the physician certificate statement for non-emergency ambulance services, also known as a PCS. So all these forms are really important with this program and really important to make sure we fill them out correctly and we turn them into the chief. But this process literally is as easy as 1, 2, 3. So when it comes to this form, it might be hard to see on your screen. Again, you should have one sitting out front of you as well that you can look at. My goal is to make packets for transfers, so we make it easier on you folks when you go to do the transfers. But just know that there's a form. The big thing about this form is you guys are physically going to bring this form with you to the nurse's station or wherever you're getting your patient report from. And both the providers need to go through this form together, and you guys both have to sign it at the end so that we know that both of you folks are on the same page and there wasn't any surprises of the care being given. So step 1 of that Lisbon EMS interfacility transfer flow sheet was a verification that an assessment was performed by the highest licensed provider, meaning we could go for a site transfer from Central Maine Medical Center back to, say, the LAMP, and we know it's a BLS transfer, but it's still appropriate in a paramedic, say if it's a paramedic level crew, The paramedic still needs to go in with the basic, do the assessment. So you do your introductions, take a look at the patient chart, any documentation that they give you, look at the last set of vitals, assess your patient and determine that this patient is appropriate to not be a paramedic level call or advanced level call. And that way there you guys are on the same page. That's step one of the form. So you guys would make that assessment together after talking to the staff and getting all your documentation together. And then you would cross-reference that with the form or the chart listed on that in-facility flow sheet. So what I did is we kind of discussed recently in this program the difference of care provided between a basic and advanced and a paramedic. I tried to give this as a visual diagram that broke down that same exact criteria, so it's something easy for you guys to kind of look at the patient, look at the history, look at the orders, and see what care is provided and which is you're going to need for a license level in the back, which is appropriate person to put in the back with a patient. Again, the goal is to safely manage the patient. If there's any question at all, and it might be advanced or a basic, or it might be an advanced or a paramedic, the highest license level, hopefully being the paramedic on that call, should just take it. Again, be a patient advocate. Step number 3, before you transfer your patient to the stretcher, this is really important to gather all of your forms and get them signed and make sure they're legible before you put them on your stretcher. Please know that part of this process with us setting up the second rescue and doing these transfers is to make sure we get paid for them. So if we transport a patient without an EMTALA form or a patient demographic sheet form or the PCS or anything of that effect, we will not get paid. So it's really important that we get paid for this, and the liability is taken care of with these forms being documented. Big thing is to make sure we get the right staff, as we've kind of discussed before. If it's an advanced or paramedic level transfer and we don't have those license levels on the truck, we need to refuse the transfer. It is not appropriate, again, can't say this enough, for the hospital staff to stop care or lower the patient's level of care being provided just to make sure it meets the needs of the lower license level crew. That is not appropriate. And we need to advocate for our patients to make sure they get the right care. So the documentation requirements here for Lisbon EMS. So we know that Holly Byron is our QA/QI coordinator. She's the one that's going to be taking care of all of the QA/QI for the 911 side. The chief has asked me, since I stood this program up, to review all of the inter-facility transports. So what he's looking for and what I'm looking for when we review these PCRs is to make sure that inter-facility transfer flow sheet is filled out. All the 5 different questions are answered. Make sure you circle yes or no. Make sure both providers sign the bottom with the date of service and the run number. Make sure that the EMTALA sheet is completely filled out to include a legible physician's name. We are requiring you to put the doctor's name on that EMTALA into the narrative, somewhere in that narrative. The doctor also should provide a provider's order form that usually is the back page of that EMTALA that kind of explains if it needs continuous EKG monitoring, if it needs regular blood sugars, if you can stop the fluids normal saline running after the blood pressure gets to a certain range. If anything at all, it should be on this provider's order form. It's also important to make sure that the physician certificate statement for non-emergency ambulance services, so we'll refer to it as the PCS, is completed by both the EMS and the physician prior to departure. And then we're really steering people towards electronic billing section of the PCR. So we need to make sure that the patient, if they're able, like we do on our 911 calls, that we go into the signature section of our electronic PCR, check the correct boxes off. We'll go over to that later on in the presentation, and then have that patient sign the electronic PCR. All of these forms need to be completed and given to the chief in one of the envelopes upon completion of the call. As always, and per our department policy, it's important to make sure that the PCR is completed within 4 hours of the call to ensure accuracy. So to include in the narrative, it's important to make sure we include in the narrative the doctor's first and last name who signed the EMTALA, the description of any interventions and medications given to the patient prior to us accepting the patient, a description of any EMS interventions or assessments that we perform both bedside before we left as well as en route, and then upon transfer of care at whatever the receiving facility is, at least 2 complete sets of vitals. Remember, the monitor is only as smart as the monitor can be. So when we sync over the vitals, that's step 1, but we still have to go in, open up the sets of vitals to make sure they're accurate. And then also include the GCS, the AVPU, the pain scale, if the pulse is regular or irregular, what's the respiratory effort, all of that stuff. Please take a moment to open those vitals up and make sure they're complete. And then lastly, again, minimum expectation in these narratives is to clearly document how the patient went from the receiving facility to our stretcher, how they were positioned during the transport, and then how we remove them from our stretcher to, say, the ED bed or the floor or the patient's house. It could be simple as patient stood in pivot, sat on the stretcher, and we secured her with a 7-point restraint harness. And we arrived at the ED, and the patient was slid over by a 2-provider sheet slide. Something as simple as that is all we're looking for. So here's a copy of that flow sheet. Pretty simple. I just took the 1-page document and cut it in half so it would actually be large enough to see on this screen. So again, the first thing we do is make sure we assess the patient with the highest license level in the crew. We circle yes, we did that. And then we look at our flow sheet. So the therapy provider level cross-reference sheet, which is the chart on the left, and make sure if they're on any medications, it falls into the medication list on the right. If it meets those 2 requirements, we circle yes. Then we go to question number 3. Do you have that signed Ventolin and PCS form in your possession, as well as is it legible? We need to make sure this is a good time to have the patient ideally sign the electronic version of the PCR, but if they're unable due to their medical status, or they have dementia or Alzheimer's and they have a medical power of attorney that's not present, we just have to make sure we have the nurse or doctor sign on their behalf, just like we would do on now on one call, and then make sure we always get a hold of that patient demographic sheet. Again, the lead provider will print his or her name, and then underneath it they'll sign it. The secondary provider will print his or her name. Again, they will sign it. Make sure you don't forget the date of service that we're doing this, and then our department run number. So here's a snapshot of the EMTALA form. So the EMTALA form, this one actually comes from Midcoast Hospital, but they're all pretty much the same. Has 2 sides, a front and the back. The front is usually what's filled out, and then the back side kind of explains the front. What's important for us, most important for us with this EMTALA, is in the lower right-hand corner where it says physician signature. We need to make sure that they have a signature, and then they do the date and the time that this transfer is occurring, and then underneath it, please make sure they print their legible name, because this is the same name that you want to put in your narrative. So again, really important that it's not only signed by the physician and dated, but they also print their name underneath. So here's that provider's order form that's usually attached or somewhere in the vicinity of the EMTALA. This should have a patient sticker on the top of it. It'll kind of give you a synopsis of any treatments that they want continued from point A to point B. And sometimes if there isn't anything, especially if they're being just discharged home, you may not receive this form, or it's blank, or it may just simply say no orders. But if it's something for you to ask for if you're doing a transfer, to make sure that you get it if they have one. So here's that physician certificate statement for non-emergency ambulance services. So this is our important piece for making sure that this trip was authorized. So the way it should be filled out is we as EMS providers are only responsible for the top section. The rest of the form needs to be filled out by the physician. Please do not try to help the nurse or doctor out and fill out the middle and the bottom for them. That is actually fraud. So please don't do that. So all we're responsible for is the top section 1, and then the provider doing the transfer should fill out the middle part and make sure they sign and date with their printed name at the bottom. So here's an example of me as the patient of how this form should properly be filled out by us. So again, we're only doing section number 1. Handwrite their name and their date of birth in there. The insurance number is not important because we'll get that at a later time. If you can get a patient sticker, that's perfect. Put that underneath the insurance number. That'd be excellent. Also, it's super important that we include, the date of transport as well as the origin and destination. So it has to be documented a certain way. Remember, our billing is done by somebody out of state. So they don't know if we just put CMMC as the origin and the LAMP as a destination. They have no idea where that is. So it's important for us to put the facility name that they're coming from. So in this one, for example, Central Maine Medical Center, and the town, the state, and the zip code for that location. Same thing with the LAMP. Simply put the LAMP, Lisbon, Maine, 04240. And that's all we're looking to have you fill out on that form. Remember, the middle part and the bottom is then filled out by that healthcare provider. So the patient signature section, it's important. So you as a provider will do the EMS provider signature like we do on all of our PCRs. And many of you do a really good job of capturing this electronic patient signature on your 911 calls, which is spectacular. Again, our goal is to move away from any paper forms that we can, because it expedites the billing process and it makes it a whole lot easier on the chief. So when it comes to the patient signature itself, type of person signing will be the patient. For the reason, please make sure you take a moment and go in and get the drop boxes of the HIPAA acknowledge form, the patient belonging receipt if they had any belongings on them, permission to transport, permission to treat, release for billing. You stamp it with the date and the time. You backfill the patient's name, and then you have them sign it. And then go ahead and lock the signature when you're done. If for some reason you don't find any belongings of the patient, clearly you wouldn't put the patient's belonging box in there. But for all of our patients, the HIPAA, the permission to treat, the permission to transport, and the release for billing should be included in that Dropbox. So what would you do? So what the next half a dozen slides or so were scenarios on patients that we would potentially be asked to transfer. So remember, when we field a transfer request, it usually goes through the chief or the deputy chief. And either Jim or Amy have a pretty good idea of what it is, or even dispatch does. So a lot of times we'll be dispatched to, say, Midcoast Hospital for BLS transfer back to the LAMP, for example. So that's a pretty common dispatch reason for us. But sometimes we might get dispatched to scenario one for just a 25-year-old patient with difficulty breathing, need to be transported from Central Maine to Maine Med. That may be all that we get. So hopefully through that screening process, Jim or Amy would look at the crew that's on. If we have a paramedic level crew, we'll take it. If we don't have a paramedic level crew, it's going to be turned down. So let's say we have a paramedic level crew and we head over to Central Maine Medical Center. So you walk into the ED and you see a 25-year-old head injury patient who is sedated on a vent and has a no-repi drip, currently with stable vital signs, requiring transport from Central Maine to Maine Medical Center. So by pulling out that Lisbon EMS interfacility transfer flow sheet, number one, you guys go in and assess your patient. Hopefully a bunch of red flags will trigger when you see what the patient even looks like. And then you pull out the cross-reference transfer sheet and you will quickly realize that this patient is way out of our scope. Again, we're not PIFT, so we can't take patients that are vented or sedated. They need respiratory therapy or life flight and main to manage these patients. It is not, absolutely not appropriate for staff to DC the vent, put on end tidal, and have you ventilate the patient from Central Maine to Maine Medical Center. That's a old school practice that is very detrimental to the patient, so please do not allow that. This sort of transport should be a refusal. The patient's unstable and it has a high likelihood of decompensating during transport, and the current treatment and care falls outside the normal scope of practice of a paramedic. So that should be pretty cut and dry. That should be an automatic refusal. Scenario number two. So we get a transport request. Amy and Jim, so the chief and the deputy chief, have approved it. So we go for a 78-year-old patient on 2 liters of oxygen via nasal cannula who has an IV lock in place requiring transport from Midcoast to Maine Medical Center. So 2 people show up. Both of you guys do the assessment. Whoever's the highest licensed level provider is the one that should be assessing this patient. You determine using the flow sheet. The patient's on basic oxygen therapy. There's an IV in place. BLS assessment to include lung sounds. This falls underneath a BLS care patient. So we would accept this transfer. So again, using that flow sheet should help you greatly on determining whether or not you'd accept that patient or not. Patient's more or less stable, currently being treated with, again, basic oxygen and IV lock in place. This is a BLS transfer. Scenario number 3. Jim, the chief, and the deputy chief receive the phone call. They accept the transfer for a 59-year-old post-hip surgery and rehab patient needing transport from Central Maine to the LAMP. Again, the first person goes up, or the crew themselves, the highest license level, they go up to the patient after getting the report from the nurse. They look at all the documentation, they look at the flow sheet, and you guys determine you can accept this patient. We've actually transported these sort of patients before. So the patient's stable, BLS level. Again, if the advance wants to take it to the paramedic, they absolutely can, but just know that this is a BLS level transfer. Scenario number 4. So the chief and the deputy chief just get a request from Central Maine's ER to go to Maine Medical Center's ICU for a post-ROSC patient. That's all they get. So we show up. We find a patient in the ED, a 47-year-old patient post-ROSC, let's say coming from Turner, who's sedated, ventilated, and has arterial monitoring, a propofol drip, needing transport to Maine Medical Center from Central Maine. And you have a life flight crew standing by to help you. Are we going to accept this patient? So going through the flow sheet, remember we kind of mentioned earlier on, if you need to take additional staff to do this transfer, it is not appropriate for us to be their mode of transfer. Meaning if this was a 911 call when we request life flight in Maine, we absolutely obviously take the patient because life flight's on board. We take them to Central Maine or Maine Med and we're good to go. It's different when you get into the transfer world. This patient needs to be taken by a PIF level service and or a life flight in Maine. So this is one, this patient's unstable and they need to be transported with life flight in Maine on board. We would refuse this patient. No different if we had a patient who was vented that we needed to take respiratory therapy, or a patient who was on antibiotics running and we need to take a nurse. Those patients are unstable and it's not appropriate for us to transfer them because, again, we are not a PIF service. Scenario number 5. A 48-year-old sepsis patient with a medication pump infusing lactated ringers and an antibiotic needed transport from Midcoast to Central Maine. Hopefully this patient would have been caught by either the chief or the deputy chief, but maybe all they got was a 48-year-old sepsis patient needing to transport from Midcoast to Central Maine. So we bring our flow sheet up to the floor with us to meet the patient. We quickly realize that the lactated ringers isn't an issue, but the antibiotic is an issue. You need a nurse. Sepsis patients are typically super sick, so they have a high risk of deteriorating, and they're unstable. So this is a patient that even though we could take a nurse with us, it is not appropriate because of the additional staff. This also is one of those scenarios where it is not appropriate for us to accept the transfer upon them DCing the antibiotics. What they need is the antibiotics, so that needs to continue. Now, if we were to show up to this case and there was 6 minutes left on the antibiotic, I would sit there and wait that 6 minutes, work on your assessments, get your documentation together. Once that antibiotic is complete and now they just have IV fluids to kind of supplement their pressure or to keep them hydrated, then it would be appropriate for us to take. But if they have antibiotics running, it is not appropriate for us to take. Nor again is it appropriate for the facility to stop infusing those medications just for us to take the patient. Scenario number 6. So we have a 61-year-old patient with an end STEMI, recently completed a round of heparin and Plavix, needing transport from St. Mary's ED to Maine Medical Center's cath lab. So do we accept them or not? So we go up to the floor, we meet our patient. Because the patient, even though the patient's having an end STEMI, right? Because remember, that's a non-ST elevation MI. So this is typically determined by lab work. So your troponins are elevated. They have already given kind of that first round of medication. Typically, the doctor's orders for this would be continuous EKG monitoring, treat as a normal MI. So if they started, having the ST elevation, we would do the nitrates, which we can do. We can go ahead and give them fentanyl for pain medication. So that's something we can handle. So as long as those meds are completed, that are in the PIF protocol, prior to us transporting the patient, you just make sure you document in your narrative that this was given and that was given and this was given and it was all done by the time we leave. So you literally write in the narrative, heparin and Plavix given and completed upon arrival, and you just did your continuous EKG monitoring and monitoring your patient. This is an appropriate patient for us to take. Again, paramedic level, as we kind of discussed, anything requiring EKG monitoring, doesn't matter if it's a 4-lead 12 or continuous or a mixture of both, it is a paramedic level call. Because again, basics and advanced EMTs cannot interpret EKG rhythms. Scenario number 7, we've all seen or been part of these ones. So a 61-year-old patient, dementia, with a Foley catheter needing transport from St. Mary's ED back to the LAMP. Again, you go in, you talk to the staff, you take a look at the Foley. That's all they have. They're cooperative, even though they have dementia. If they were not cooperative, I would highly recommend a paramedic level taking this. If they're uncooperative, because again, we can give medications to calm them if we need. But for all intents and purposes, this is a BLS transport. Remember a Foley catheter. So that is a tube that goes into the patient's urethra, whether it's a male or female. That is a basic level skill, meaning in a nutshell, the big thing with Foley catheters is to make sure that the bag of fluid is empty, so empty of urine prior to you transporting them, because you don't want that spilling all over your stretcher or the ambulance. The big thing is to make sure that the tubes themselves, the tube of the catheter, is not kinked, it's not looped, it's not tied, it's not cut off, and that the bag itself is hanging below the level of the bladder. And then typically these patients shouldn't be yanking on these tubes either, and usually they're secured to one side of the leg or the other with some sort of dressing or even a strap. But again, this is a basic level transfer. So you got this. This is the conclusion of the presentation. Take-home messages. Remember, these patients are already in a healthcare facility. So this is a time for us to take as much time as we need to make an educated decision on whether or not we should be transporting these patients safely. Always use our interfacility transfer sheet in your decision-making capacity. Make sure all your forms are completed prior to us leaving. So get your signature that you need. Make sure the entitler is readable. Make sure the doctor's name is readable. Make sure you have that PCS also signed. You completed the top. The destination is accurate with the town and the zip code. The physician has signed the bottom and they've printed and dated their name. As always, anytime you have questions with any of this, please feel free to call Chief McDonald, and that's a cell phone number, or myself. So Jim's number is 406-1040, and mine is 671-7984, with any questions regarding this at all. So the last piece of this presentation is you should have a quiz out front of you. Please complete the quiz. Give it to the chief. The chief will correct it, and then have you sign the EMS roster for CEHs.